So again, a warm welcome to our fetal cardiac MRI webinar series. Today, our first session in 2026, our spring session. Please note that this webinar will be recorded. So our moderators today will be Fabian, which I think a lot of people, of course, know, the founder and CEO of North Medical, and myself, Leah Meyer. I'm working in business development here at North. Always as usual, this webinar is a place to connect, exchange, and learn. So we're really doing and organizing this webinar that we can build a community and that we can offer a platform for you where you can network and exchange and of course ask questions. Feel free, it doesn't matter if you're just starting with fetal CMR, if you have no experience at all or quite some experience, please feel free to actively participate here and join the discussion. We are very interested in that and looking forward to that. If you have questions, you can put them directly into the chat. We will have, of course, a look at it then in the end. So we just walk through the presentations and then in the end have a look at the questions in the chat, or you can also raise your hand here via this Teams function that you want to show us that you want to speak if you have a question directly to one of the speakers. So today is our spring session, as I mentioned. This topic of this session is clinical cases in fetal cardiac MRI and their influence on patient management. It's the first session. We already have planned 3 other for this year. We make sure that you get the invite for all the other sessions, but today we start here with the spring session. Of course, then I'm very happy to welcome our 3 speakers here today. We'll start with the fetal and pediatric cardiologist, Dr. Jyothsna Akam-Venkata from Joe DiMaggio Children's Hospital. After that, we will continue with Dr. Max Godfrey, the Director of Congenital Cardiac Imaging Service from Shaare Zedek Medical Center. And finally, I'm happy to welcome Professor Dr. Bettina Reich, pediatric cardiologist with expertise in cardiac MRI from the German Heart Center in Munich, who will present clinical cases here today. And if you're ready, I'm very pleased to welcome as a first speaker, Dr. Akam-Venkata, And please feel free to share your slides and start with your presentation.
Hello, everyone. I'm Jyothsna. Thanks for the introduction, Leah, and thanks to North Medical Center for creating this nice platform for all the fetal CMR enthusiasts to come together and share our knowledge. So I'm from Joe DiMaggio Children's Hospital. I do pediatric cardiology and fetal cardiology and advanced cardiac imaging here. Over the next 10 minutes, I'm going to talk about the role of fetal CMR in the prenatal evaluation of cardiac tumors, and I'm going to do so using a case-based presentation. So I'd like to go over how the patient was presented and what was concerning on the ultrasound imaging that led to the fetal CMR imaging and how we did that and the images and what happened to the patient postnatally and how the fetal CMR influenced the care of this patient starting from prenatal life. So here is the fetal echocardiogram performed at 22 weeks and 6 days gestation on a 30-year-old primigravida mother. And the first thing we see is that there is a mass seen in the chest, immediately inferior to the left ventricle. The patient was referred for the concern for cardiac mass. But we can see that it's very close to the apex of the heart, and we were initially questioning if it's attached to the heart or if it's just inferior in close proximity to the heart. And then in this sweep, you can see that it's just by the stomach bubble, which also shows that it's not in the exact same plane of the heart itself. And I believe I'm missing a slide, but there's also, this is a follow-up scan at 32 weeks gestation. And you can see that the mass had significantly increased in size. The mass increased from about being a centimeter to 2.2 2 centimeters across 2 millimeters in size, but there's also additional mass. Even in the first ultrasound, if I go back, there was a concern for an echogenic structure seen in that interventricular septum, but it was very small. It measured about only like 2 millimeters in size on initial presentation. But at 32 weeks, you can see that echogenic mass by the interventricular septum is much larger in size. It's about a centimeter. And there's also another mass in the RV myocardium situated inferior below the level of the moderator band. There's an additional mass seen at the LV base, just immediately beneath the mitral valve apparatus. So at this point, there is multiple cardiac tumors, and here it's more clear that it does involve the heart and the apex of the left ventricle, but how much of the extension is there in the extracardiac structures was not very clear on ultrasound imaging. And here you can see how there is some compression of the left ventricle, and that would raise the concern for if there's any ventricular dysfunction from this. There's no significant pericardial effusion, and the mass is very homogeneous in appearance, which makes cardiac rhabdomyomas as the first differential on the list of diagnosis. So this led to planning a fetal cardiac MRI. So the patient was brought to the scanner at 36 weeks and 4 days gestation. The fetal heart rate gating was done using the SmartSync device, using Doppler ultrasound fetal cardiac gating. We did the scan on a 1.5 Tesla Siemens magnet, and the following protocol was used, starting from localizers and T2 black plus haze images, cross-coronal transfers and sagittal planes for the mother and also for the fetus. And then we did the cine imaging of the heart and tried to assess left ventricle and views of the heart from various planes, port chamber, axial stack, and short axis stack, and as well as we assessed the flows. So here I'm going to show the images. We see the cine of the 4 chambers from anterior to posterior, and we can identify the 2 cardiac masses. We can see the large mass involving the apex of the left ventricle, and that's about 23 by 22 millimeters in size. And then we see an additional mass involving the interventricular septum, but it seems to protrude into the left ventricular cavity and also the right ventricular cavity. And we can see that there is the delineation from the lung parenchyma, which is actually better appreciated on T2, but we can start to see that this is not a mediastinal or extracardiac structure, but this is a cardiac tumor. So the next one here is a 3-chamber, or rather, I should say, this is the LV outflow tract cine. You can see there's unobstructed flow across the LVOT, and there's no intracavitary obliteration or obstruction. So in the case of a mass that's increasing in size through the course of pregnancy, one of the key factors that will alter the delivery planning and outcomes, what we would do is there any ventricular dysfunction? Or is there any outflow tract obstruction, or is there any effect of valve or regurgitation or compression of the venous structures? These raise the red flag for hemodynamic compromise, and we may even consider exit procedures in these patients, or immediate neonatal intervention would be planned. So we were able to reassure that there is no significant compromise in the cardiac output for this patient. This is a short axis cine stack looking at the ventricular function from the apex to the base of the heart, and you can identify the tumor, the smaller tumor here. And this is another view of the left ventricle. It's like, I would call it a modified 2-chamber view, because we see a little bit of the RA contaminating the view, but we were able to assess the function. I think my video is playing a little slow. But using the volumetric analysis, the left ventricular ejection fraction was about 62%. The right ventricular ejection fraction was 51%. This is a T2 weighted imaging of the 4-chamber, trying to visualize the mass. I think through screen share, the image quality does get further degraded, but you can see right here by the apex is the mass. It's not hyper intense. It's pretty close to the intensity of the myocardium. Okay. And then we also did, this is the T2 survey or transverse view of the fetus, starting from the abdomen all the way up to the head. And it's pretty fast. I'm going to run it slow for you guys. So you can see right there, there are multiple renal cysts located in the right kidneys that was not previously detected on the ultrasound imaging. And presence of multiple renal cysts is one of the manifestations or renal manifestations of tuberous sclerosis. And in the context of cardiac rhabdomyomas being the highest differential, the most common scenario here is tuberous sclerosis. And you can also see the cardiac mass here, the large one, that is not hyperintense or isointense. And we can see very nicely that the lung parenchyma is normal. There is no involvement of the lungs. This is axial cine stack starting from the liver to the outflow tracts. So this is to evaluate segmental cardiac anatomy in addition to assessment of the function. So here we see that, slow this down. The hepatic veins drain into the inferior vena cava, which drains into the right atrium. We see the flap of the foramen ovale, and there is atrioventricular concordance, and we see the left ventricle giving rise to the aortic outflow, and then the right ventricle giving rise to the pulmonary outflow. And we demonstrate the three vessel view here. You see the superior vena cava, and that's the trachea. And you see the left-sided aortic arch and the left-sided ductus arteriosus. So this is a good correlation to the three vessel trachea view that we obtain on echocardiogram. So this is to demonstrate the feasibility of segmental cardiac anatomy analysis, which will come handy in complex congenital heart disease. So these are postnatal images, echocardiogram. We see the large apical cardiac mass, and also we see the second mass in the interventricular septum and the one in the right ventricle. Another view of these three masses, we see one by undersurface of the mitral valve, base of the free wall of the left ventricle. Kind of move on to the next slide. This is 7 months later. You can see that the mass has significantly regressed in size, which is very classic for rhabdomyomas. You can see the one by the septum is essentially not there. It's resolved or regressed. And then the apical mass was like really hard to see, but even if we see some residual, very small 2 millimeter structure. So the patient had a very good postnatal course from a cardiac standpoint. So we did obtain further imaging, especially to evaluate the extracardiac structures. The renal ultrasound showed several cysts noted, and which was picked up on the fetal CMR. And the brain MRI showed multiple tubers of the brain in subcortical and cortical region, and also subependymal nodules, which are all very classic for tuberous sclerosis. The baby was asymptomatic, observed in the NICU with the level of care 2 assignment, and after 4 days of monitoring and initial evaluation, the baby was sent home. At 5 months, patient had seizures, infantile spasms, led to hospitalization and reimaging of the brain, which detected increasing in the size of the brain tumors and also development of a giant cell astrocytoma, which is the most common tumor seen with tuberous sclerosis. Patient was treated with everolimus and also anti-epileptic drugs. The genetic panel showed a mutation in the tuberous sclerosis 2 gene. Was reported as variants of unknown significance, but I would think this is very significant and very relevant to the phenotypical presentation. So how did fetal cardiac MR help in the prenatal care of this patient? It did help in the comprehensive evaluation of the tumor, especially when we're able to visualize out the apex and outside of the apex of the heart much better, and that's a little bit superior to the resolution of what we can see in the ultrasound. And it was able to rule out the involvement or lack of involvement of the lung parenchyma, in addition to looking at the tumor itself, the location and the extent. And we can assess for the hemodynamic effect of the tumor by assessing the function, both by qualitative and quantitative measure, and rule out any outflow tract obstruction. And in our case, we also were able to identify the renal cysts, which helps with bringing in other subspecialists to increase the level of care for the patient. And based on these findings, in addition to the echocardiogram, we were able to assign the level of care to, which is higher than the routine newborn care monitoring, where they are observed in the NICU and assessed for all of the things like arrhythmias and telemetry. But however, level of care two is an indication that there is no expected immediate postnatal intervention, in which case it would be escalated to level of 3. So we're able to appropriately triage the delivery and the postnatal care or neonatal care. And also, more importantly, from an academic standpoint, it helps us understand the natural history of the rhabdomyomas. We all know that most of these rhabdomyomas are diagnosed either in infancy or prenatally, and they regress in size. But having seen this tumor early enough, it led us to follow from early pregnancy to late pregnancy, where we saw the tumor first increase in size and then it became smaller postnatally as the child grows. And it's understood that the effect of the hormones from the maternal circulation, especially progesterone, has an influence on the growth of these tumors, which is why these tumors, if they're caught early enough, they do increase in size first and then regress. So I think that was a nice demonstration from this case. Additionally, the fetal CMR does have added benefits of not really needing sedation for the mother or the baby. And we don't use contrast, there's no radiation. These are pretty obvious. The risk exposure to the magnetic strength and energy deposition, but several studies have shown there is no reported adverse events on the postnatal follow-up of these fetuses, with no increased incidence of congenital anomalies or neoplasms or fetal growth restriction or visual or hearing impairment. And they've had no significant neurodevelopmental impairment following exposure to fetal CMR or fetal MRI itself. And in patients, which we see a lot of patients with, either high BMI or very difficult scan because of unfavorable fetal positions, we bring in a large referral tertiary care center. We do sometimes get late referrals. So at that point, ultrasound imaging is less optimal because the baby is in an unfavorable position and is stuck with the shadow from the bones and other structures. Or in case of oligohydramnias, and also the fetal CMR is less operator dependent. These are all nice advantages. So for these reasons, the American College of Obstetrics and Gynecology and American College of Radiology support the use of MRI when in evaluation of any fetal anomaly when the ultrasound imaging is not sufficient. We do have limitations, especially when it comes to the characterization of the cardiac masses, because we don't administer gadolinium contrast. It does limit the full spectrum of characterization, such as not able to assess the first pass perfusion of gadolinium and vascularity and late gadolinium enhancement, which is really helpful in differentiating between rhabdomyomas and fibromas, which can appear pretty close, especially if the rhabdomyomas are large in size or fewer in number. And also, the quality of the fetal CMR is very dependent on the fetal motion and accuracy of the cardiac gating throughout the scan. We've had several cases where the gating was great when we started, but soon we lost the gating and we've had to redo. And those are all some of the limitations. The maternal discomfort, despite providing adequate support pillows and all that, most of these moms have a very uncomfortable experience being in the scanner for 45 minutes to an hour, and often have to change positions even during the scan. And the size matters. Such small sub-centimeter cardiac masses cannot be fully assessed using MR, which is why MR is an excellent complement to ultrasound and comprehensive evaluation of these tumor masses. I'd like to thank several members here. First of all, Domenico, he has helped a lot by coordinating with our team whenever we have issues for troubleshooting, and also helped sending the protocol for our first case. So that was very, very helpful. And I'd like to thank our pediatric cardiac MRI technologists, MR educator, radiology managers, who've all shown very great level of enthusiasm in starting the fetal CMR program. And I'd like to thank my pediatric cardiac imaging colleagues at Joe DiMaggio Children's Hospital, as well as the fetal cardiology team at Jody Children's Hospital, which is a part of the Memorial Healthcare System. I'd like to thank my pediatric radiology colleagues who are always willing to take an additional look and look for extra cardiac structures and anomalies and work very collaboratively with us. And most importantly, I'd like to thank all the patients and the volunteers who are helpful in understanding the fetal CMR and how we can advance the field. So thank you so much for the attention. So this is the map of South Florida. So we're right here in Hollywood, a little bit north of Miami. This is the tertiary care hospital, but you can see there are several off-site locations where fetal screening echocardiograms and fetal clinics are all performed, or fetal cardiology clinics. And all of those patients, when they require higher level of care, they get delivered here at Hollywood, which is where our heart center is.
Hey, great. Thank you so much for this interesting case of the tumors. I think it's really a crucial point that you also mentioned, that with the information of echo and then doing this additional fetal CMR to decide on the level of care, what you just showed here on the map, to decide where the delivery needs to take place. So I think it was a really great insight already. I'd say in the matter of time, we just jump into the next, for the next presenter here. As I said, we have, I'm sure, time in the end to discuss a little bit. If you have questions, as I said, you can just put them in the chat and then we discuss in the end. And then I would like to hand over to Max. Feel free, please, to share your slides, and great that you're here.
Okay. Good evening, everybody, or good afternoon, or good morning, depending on your time zone. It's a pleasure to be back here on this webinar, and I'm going to be presenting two cases where fetal cardiac MRI was used as an adjunct to fetal echo, both revolving around coarctation of the aorta in the context of sort of more complex heart disease. Okay, so the first case is was a fetal echo that was performed at 22 weeks gestation that revealed a hyperplastic, very narrow left ventricle with a subaortic VSD, a hyperplastic arch, and a severe coarctation. And excuse me. And then that fetus was studied again at 28 weeks by a different physician who changed the diagnosis somewhat. So that actually was an unbalanced AV canal with a hyperplastic left ventricle, sort of a right dominant AV canal with a clear antegrade flow and no coarctation. They were quite adamant about that. These are two separate physicians, and I'm not either of them, at least in this case, as it happens. So there was a clear discrepancy between the two, between these two echocardiographers. I managed to get some pictures from those echoes. I think this one is from the earlier one, actually, but we can see clearly a very right dominant heart here. Here we can get more of a sense that it's not the best, perhaps, but we can get a sense that it's maybe an AV canal with a premium defect there. And here are some images of the aortic arch, especially when it starts playing. And as you can see, this looks like a pretty well-sized aortic arch with normal flow profile, of a robust flow, antegrade, sort of everything looks pretty good and normal about this aortic arch. So, if in doubt, fetal cardiac MRI will help you find out. I think maybe we can make this our strapline for future webinars. But I think this maybe in brackets, in parentheses at the bottom, is going to be pretty important, and maybe we'll come back to that at the end. So here's an axial stack. I'm a big believer in axial imaging in prenatal and postnatal MRI. I think you can get a lot of anatomical and physiological information from the axial stack. And I'm just going to let this run for a few seconds just so that everyone can get a kind of gestalt of this heart, and then we will sort of go into some luminous green detail about what's going on here. So if we start, let me just give myself a pointer. If we start here at this bottom panel here, so you're going to have to trust me that this is left, and we have here cytosolitis. We can see here the IVC going into the right atrium. We can see the descending aorta right here, and the heart pointing to the left, and that's pretty good. Although already from here we can get a sense that we have a much larger right ventricle than left ventricle. If we move over to here, which is more like a kind of apical four-chamber view, we can appreciate this is indeed an unbalanced AV canal. And if I know how well this projects on across the across the internet, but you can see that the atrial septum here is billowing bidirectionally and actually quite a bit more left to right rather than right to left. On this picture right here, which is slightly more cephalad, we can see again this large right ventricle, the small left ventricle. We can see here coming in and out of the plane a normal broad-based right atrial appendage over here. We can see a more finger-like left atrial appendage over here, and we can get a sense of pulmonary veins coming back from each side, normally to the left atrium over here. And then moving up to these two panels here, we can get a sense of the three-vessel view. So we can see a large MPA and ductal arch here, a little bit of the right pulmonary artery coming off over here. And as we go slightly further up, we can see the transverse aortic arch here, which is clearly much smaller than the ductal arch. So now we're going to try and focus a little bit more in on those arches. So here we can see in this still a beautiful ductal arch coming from anterior to posterior and joining the descending aorta. And in the cine of that, we can again see this beautiful ductal arch with perhaps a little glimpse of what looks to me like a much smaller transverse aortic arch plugging in over here. And we're going to look at that in a little more detail. So on this image here, so again, we can see the main pulmonary artery, the ductal arch, the descending aorta. We can see that one of the pulmonary arteries right here. And we can see this transverse arch here kind of plugging in to this larger ductal arch. And this is a picture that I find very useful when I'm talking about coarctation in the fetus. And unfortunately, I don't remember who I stole it from. I've also stolen it from a paper, and I haven't credited it, and I apologize for that. But I find it's very useful that if we look at the normal fetus here, so as we expect, we see a sort of aortic arch and a ductal arch, and they're kind of contiguous, and these sort of seamlessly blend into one large descending aorta here. Whereas in the fetus with a coarctation, we can see that we have the dominant ductal arch with the aortic arch kind of sort of piggybacking or plugging into that, giving us this sense of this posterior shelf right here. And I think this is what we're seeing here. I've frozen this image, and we can see this, again, this ductal arch here, this aortic arch here, and it's kind of plugging in like that, very similar to this picture over here. Second. This is a slightly different projection in a cine. It's coming out a little less clear, especially on the share screen. But here we have a very nice sized descending aorta, and here we can appreciate this little kind of elbow of the aortic isthmus, again giving us this kind of figure of three picture, sort of very consistent with this image right here. So very suspicious for coarctation. So now we need to really put our money where our mouth is, and what are we going to say in the report? I said that this was most consistent with levocardia, unbalanced AV canal, right dominant, with a small aortic arch, with most probably coarctation of the aorta. And this most probably is going to be something that we're going to come back to perhaps at the end. Let's find out what actually happened. The baby was delivered actually in a surgical center, not in my hospital. And the postnatal diagnosis confirmed the unbalanced AV canal with right dominance. They saw there was large primum ASD, which is actually interesting because on the MRI images, I wasn't totally convinced that there was a large primum, even though the echo obviously was very suggestive, as we saw. But with the large inner BSD, which we saw, and the hyperplastic aortic arch started on prostaglandin and requiring a stage 1. So we were, MRI was able to contribute in this case. We were more accurate. We were able to see what was really consistent with postnatal diagnosis of coarctation of the aorta. Okay, now the second case was a fetal echo done at 17 weeks. Full disclosure, this one was on me, for better or for worse, as you'll see. And a OBGYN colleague had referred this lady for abnormal appearance of both the aortic and ductal arches, sent them to me for a fetal echo, which I did at week 17. I found clear ventricular disproportion at this very early gestational age, and what I thought was a pretty clear coarctation. And here we can see some images. I've got a feeling this may be from subsequent echo. I think this was week 18 already at this point. We can see nicely here the aortic arch piggybacking again onto the descending of the ductal arch and descending aorta. In this sweep, we can see that the right ventricle is bigger than the left ventricle. And here we have a 4-chamber view showing again that ventricular disproportion. And then, unfortunately, I get the dreaded phone call from which none of us want to get, from a senior, well-respected and admired colleague of mine, who said that honestly, they're not sure at all this is a coarctation, but how on earth did you miss the Epstein anomaly? And indeed, I had missed Epstein anomaly of the tricuspid valve. And he summarized it as Epstein's with a mild coarctation. I'll just show you some pictures from his scan. And you can see that whilst, again, he found this sort of figure of 3 of the aorta, you can see that actually, as far as the dimensions go, you can understand why he was skeptical, because nothing looks that small, nothing looks that narrowed. Here we can see that there's a clear apical displacement of the tricuspid valve and a kind of eccentric jet of TR going on right here. So again, perhaps fetal cardiac MRI will help us and will save the day, perhaps. So here we have some cine images. We have a 4-chamber projection here, and you can kind of get a sense of the apical displacement here of the tricuspid valve. This is a very clear Epstein. There's a little bit of septal bounce as well, for those who like that kind of thing. And if we look here at this sagittal view, so just for those who aren't fully oriented, so this is spinal column, so this is back, this is posterior, this is anterior, this is the right atrium, this is the right ventricle, here's the tricuspid valve, and we can see a pretty robust jet there of tricuspid regurgitation. So I'll just let that play for a second so you can get that sense as far as the Epstein goes. Now we have some cines of the arch. And I thought that maybe we could see a little indentation here of this of the aortic arch as it plugs into the ductal arch. A little bit of systolic dephasing going on here, which is the equivalent of aliasing in the MRI equivalent of that echo phrase. And I thought maybe we could see a posterior shelf here and here. I felt that this image here, this black blood image, was a little more convincing. So again, we have this robust, this large ductal arch here. We have the aortic arch plugging in. We have this indentation posteriorly. And I thought this is very reminiscent of this image here, and very suggestive of coarctation. But overall, in sort of in absolute terms, nothing here was that small. And if we look at this 3-vessel view here again in the black bloods, well, notice this looks like a very normal 3-vessel view, SVC, ascending aorta, MPA ductus, and everything looks kind of appropriately sized. So I found this a little harder to put my money where my mouth is in this case, and I was a little more, I hedged a little more in this report. Commented obviously on the Epstein. I said that the appearance of the aortic arch on those sagittal views is very suggestive of coarctation with some systolic dephasing, but the axial views with a normal 3-vessel view would kind of argue against that coarctation. I should probably add also that, of course, the size of the right ventricle is less of a marker also at this gestational age, but also in the context of Epstein's with significant tricuspid regurgitation. Okay, so what actually happened? So this baby, again, was born in a surgical center, not in my own institution, was found to have anatomically severe Epstein without significant regurgitation, interestingly, and with suspected coarctation. They commenced prostaglandins immediately after birth, but stopped after 24 hours to allow the duct to close to kind of be certain. They performed daily echocardiograms, and on day 5, they felt sufficiently confident that this was a true coarctation. The baby underwent arch repair with an excellent result. They actually came to my clinic this week, and again, they have indeed anatomically severe Epstein without much regurgitation and a very nice arch repair. Here is an image from the postnatal echo that persuaded them to go for arch repair, for coarctation repair. As we can see here, there's this discrete narrowing of at the coarctation area. So I think the take-home messages of these 2 cases, I think fetal cardiac MRI can definitely provide additional anatomical detail that has a theoretical advantage of multiple slices and multiple planes. I've written here which sequence is best, and I'm not sure that a given sequence is best. I think, as we can see, the first fetus, we got very nice cine imaging. The second fetus, I didn't show you many cines because they weren't that good, honestly. And the black blood I found to be more useful. We've also done still white blood imaging and found that useful in some cases. And I think there's a lot of sort of room to play here with various MRI imaging techniques, cine and stills. And I do want to just do a little, that was maybe the good cop, but now a little bit of bad cop here. Clearly, at least currently, cardiac MRI is going to be complementary to fetal echo. And in many cases, it's going to be the same physician, or at least the same group of physicians who've done the echo and read out the cardiac MRI. And we have to be a little careful to kind of confirmation bias, finding what you already know to be the case. And you have to be prepared to challenge what other people have said. We do struggle with variable imaging quality, as I've mentioned. And that will, I think, get better as we learn. It's still relatively new modality. And again, there's a lot of hedging bets. There's a lot of most probably, cannot exclude, cannot rule out. And I think that we have to be kind to ourselves. We're still new at this. Like I say, we're a fairly young modality and we have a lot still to learn, but I still think we have a lot to offer. So thank you very much.
Great, thank you, Max. Really like the intro. When you're in doubt, fetal cardiac may help you out. That's a good one. I will write this down, maybe for further presentations. Thank you again. As I said already, we will start with our last presenter, Professor Dr. Bettina Reich. Thank you so much that you're also here. Please feel free to share your slides, and then we directly also jump into your slides and have some discussions in the end. Thank you. Yes.
So I'm from Munich. Hi, everybody. And I wanted to show you 5 or 6 cases. I don't have the ultrasounds because those are done in a different center. So I can only share with you the MRI scans of the fetus. And today I didn't show CNAs because our PAC system didn't let me to save down the CNAs in this presentation. So maybe in the next time we meet, this problem is also solved with our IT, it's very laid back. So you can go on with the slides.
Mm-hmm.
So first, can you click the slides because I can't. Next picture.
This one?
I still see the same.
Okay. Sorry.
The first slide.
Then I hope now.
I'm sorry.
Bildschirmpräsentation. Disconnect.
This one?
Disconnect.
Where? Yeah, Bildschirmpräsentation.
Yeah. Okay.
No, it's also not in the webinar, right?
What?
So another suggestion would be for the next seminar, I have the CNAs also. I can discuss my cases, and now we can also talk about a little troubleshooting, because what Max said is completely what I experienced, that some of the CNAs are very blurry still and not so sharp, and maybe we can share our experience with that. That I also had the feeling, especially regarding the duct and the aortic arch, that sometimes black blood gives you more information. So I don't know what's about the time. It's only 12 minutes left.
You're still in the meeting, right?
So now the computer from Leah just died. There was enough. There was too much for the computer for her.
It's an interesting session today. Thank you for your patience.
In the meantime, if someone in the chat wants also like to raise their hands and then ask some question, also like be free for that for sure. So in the meantime, we can just answer also some question, and
you have the opportunity to talk to specialists in that field. Take that opportunity. So we have more time.
Now here we are. Yeah, perfect.
Okay.
Can you hear you?
Go through.
Yeah.
Okay.
Okay.
So shall I go?
Nobody had questions, so it's too bad. But then,
so what are your experience with the axial stack?
Go ahead.
Because Shall I go on with the slides or shall we discuss more?
No, let's go.
Okay, so the first patient I want to show was the question of an interrupted aortic arch. The obstetric department, they thought it's a continuous but hypoplastic arch. And beside the patient had a big VSD, which was obvious. Can you go on with this slide?
Do you see the slides?
Yes, and there, what we could detect by MRI was that the aortic arch was interrupted and that it was type B, what was not seen in the echo, and what we also found that this baby didn't got a thymus, so after birth he got also genetic testing and it was a DiGeorge. And it got in the first week a subclavian flap correction and a closure of the VSD. So the more information we arch, and that it was type B. So we can go on with the next patient. This was a very complex patient. It was also very tricky because it was a lot of fluid, polyhydramnion. And because of this polyhydramnion, the movements were also very hard to deal with. But from the first pictures already, we could see that something was going on in the gut system. And what we suspected was a unal atrasia. And what we also could offer as more information was that the right lung was extremely hypoplastic or even aplasia of the right lung. And from heart side, it was a dextrocardia and complete AVSD. So this is what you see here. So the next picture. The heart is on the right side. So what you see here, the normal lung on the left, and above the heart, there was no lung tissue. So what we found, and if you click again, you see all the diagnosis, was polyhydramnion, dextrocardia, complete AVSD, common atrium, and hypoplastic, or what we said was more aplasia of the right lung, and GE malformation. And finally, the baby was born, and the first 6 weeks, it was continuously on a pediatric ICU. From the heart side, it was stable with the complete AVSD. So far, we haven't seen it, but the gut problems were fixed in this other clinic. And soon, maybe in 2 weeks, it's going to be transferred for closure of the AVSD. And the next patient. The next patient was transferred to us because the problem was hypoplastic borderline left heart. And what was unusual was that there was an ASD primo type. So it was an incomplete, unbalanced AVSD. And what they also wanted to ask us whether this borderline ventricle by size might be possible to correct for biventricular later correction. And we did volumetric measurement, and it was the time of birth, it was too small for biventricular repair. So as a first step, we operated in the first week the coarctation and did a bilateral banding like the hybrid approach. And later on, he got stage 2. Yeah, this is, yeah, keep going.
Was that correct?
Yes, there you see it. One more, stop. Yeah, on the left side, you see the stenosis of the aortic valve with this black jet. So it was a small aortic valve, and the lung pulmonary veins, they look very funny, but it wasn't malformation, but they ended up in the left atrium all at one spot. So it was an intracardial malformation of the pulmonary veins, but they didn't need any surgery for that. And the baby, please click again. was, as a summary, a borderline left ventricle, a hypoplastic mitral valve, aortic stenosis, hypoplastic arch, and incomplete unbalanced AVSD. And this intracardial suspicious pulmonary veins after birth turned out to be no need for surgery, but they were suspicious by MRI and also by echo. And this child got first a coarctation operation and a bilateral banding, and now is waiting for stage 2 operation because the left ventricle couldn't be recruited for biventricular repair. The next patient. We were asked because the obstetric people, they weren't sure what happened to the mitral valve. So this patient has a tricuspid atrasia, what you see there, also with a small VSD on the left-hand side. And what you see in the colored pictures is the pink mitral valve, which is elongated, and it was also insufficient, which is like a bad sign if you know that you go the univentricular way. And what we also could see that the pulmonary artery was normal, and the lung perfusion was also fine, because they were afraid, the obstetric department, that also there was a malformation of LPA or RPA, which we could exclude. And the baby was born. You can press again. And the mitral valve is a little elongated and looks abnormal, but the insufficiency after birth, similar to Mac's patient, wasn't that insufficient. So we ended up in this patient with a Norwood. He got a 3.5 BT shunt and is now the fourth week at our ward and is stable and waiting for stage 2, probably in 2 months. Next patient. This is this patient again. Yes, this is this patient again, showing the hypoplastic aortic arch and the VSD. Okay, and the next patient. This patient, first of all, the obstetric department said the position of the baby is normal, and then we said no, it's not. I mean, it's obvious, it's sitting on the bladder, so it's a breech presentation. So in this case, also a Caesar section was recommended. And now coming to the heart, you can show the next picture. For the heart, what we found was a truncus. And it wasn't clear from the obstetric people what type of trunk it was. And what we found, that it was truncus arteriosus type 1. And it was a little special because the LPA was coming from the pulmonary artery trunk, and the RPA was getting blood via the PDA from the truncus brachiocephalicus. And what we also found was a malalignment VSD. So we switched from the first diagnosis from a truncus arteriosus type 3 after the MRI to truncus arteriosus type 1 with a specialty regarding the RPA coming from the truncus brachiocephalicus via the PDA. Okay. Next, yeah, this is the same patient. It got, okay, this is the last patient we had in the MRI 2 weeks ago. It's 33 weeks. And the question was also what happened to the aortic arch, and whether it's just hypoplastic arch or coarctation. And we found through the axial sinus stack, we could see that it's a hypoplastic arch, not only coarctation, and also an apical VSD. Next picture. Okay, and there on the right-hand side, you see the hypoplastic aortic arch, which needed an surgery from the front and not from the side neonatally, and also the VSD could be closed. Unfortunately, the baby also had apical muscular VSDs, which at the fetal time weren't so open because the right ventricular pressure is high in the fetus, and after the lung opens, the pressure in the right ventricle lowers, and then during the first week we found that there were, like Swiss cheese, also little VSDs at the apical heart. That's why they did the operation of the aortic arch. They closed the big VSD in the first week, and then they did a central banding. So this patient will need a second, probably operation, maybe in the future, in the first year, depending whether the apical VSDs close themselves or need treatment. Okay. These are the 6 cases, only MRI, and I couldn't upload scenes, but for the next meetings we can arrange to upload also scenes. Thank you.
Thank you so much, Bettina.
Yeah, thank you, Bettina, also for your talk, of course, and showing various cases. So maybe, I mean, the time is already over, but maybe now for our speakers, where would you see the main clinical benefit of fetal CMR when you're looking now at your cases or other cases you have already performed? What's your comment on that?
For me, I would say, if I could start, it's mainly an add-on, because having the whole fetus scanned and looking on all valves like in echo is not really possible because of the time and also the movements. So what I try is to focus on the main things first, like the aortic arch or the pulmonary veins. And yeah, this is usually how I run the scan, because also for the mother, sometimes it's really hard to lay in the scanner for over 1 hour. What I'm really happy about, because I know Fabian quite a long time. When I was working in Heart Center Gießen, we had the old Siemens scanner and couldn't really make this work. But now with the Philips 3 Tesla and the new tool, the gating and the heartbeat, I always find, and the signal, if the mother is not obese, it's really good. But I still struggle a little bit with the Sina axial stacks, and I try also my artificial intelligence for, let's say, 3 to 5 year old children. So I use different sequences, what I use for little children, instead the ones who are provided from North, which go a little bit better. So I'm still working with the sequences a lot in every woman. I don't know how you guys do it. Yeah. So the first stacks are very good, the overviews, but then with the sinus, I still struggle sometimes. Yeah.
I would agree. I think for intracardiac anatomy, getting a first look at the echocardiogram is like the way to go. But CMR adds a lot of benefit to look at vascular structures and pulmonary veins, systemic veins, and looking at the arches. But I agree with arch being small and physiologically having less flow across the transverse arch and the isthmus. It's going to be a challenge. I think looking at arch using cardiac MR in addition to echo is a great endeavor, and we're like learning about it as we go. But we may not be able to 100% say predict coarctation, I think, which is also the challenge in fetal echocardiogram. But to be able to reduce the errors and help at least deliver the appropriate location to keep the babies and mothers babies safe, and also not being separated from their mothers, if you can answer that, I think that will be a great addition to the field of fetal cardiology.
I would just sort of really echo what you both said, but I mean, I've been doing this since before the SmartSync came available, and it's made a huge difference, as Bettina said. I also find, and maybe you can confirm this as well, when I try and take pictures to give a talk, it's almost always in the beginning of the study. Whatever I got at the beginning is good and usable, and whatever comes later is bad and unusable, regardless of what kind of scan it was. And I think like you say, the women, it's very uncomfortable, and it's very hard to kind of maintain the sort of to remain immobile long enough to make it really good for MRI scanning. Like I mentioned, I find axial stacks to be, and short axis stacks to be the most useful. I've had very little success with phase contrast of any kind. And that's something that I'm sort of constantly working on. And I think we have a ways to go till we really have kind of found a real well-defined sort of use case for this. But I think the more we do it, the more success we're going to have.
Yeah. Yeah.
Interesting. I think this also on some workshops, Malenka Bissell from Leeds called it the SPA approach, because it's exactly what we see is that in the first 15 minutes, 20 minutes, you have good image quality. And then suddenly you have moving features and a moving mother, because she's getting she just can't lie anymore. So it's super important that we have her as comfortable as possible, because what basically is happening is that she starts to move, which will also then affect the ultrasound signal, right? Because then the transducer will move, because the coil is pressing on it, or the cable somehow is slips away. So this has quite an influence. I've seen that some of you have used a functional analysis of the short axis, but didn't provide numbers. Are you using that in general, that you also, if you have short axis stacks, for example, that you calculate ejection fractions and so on? Are you using that in your clinics, or is that
No, I think it's more like test. We're not reporting it officially because we don't have normative values. But I was trying to estimate the combined cardiac output, which we always estimate on fetal echocardiograms, and see how MR images correlate with it. I think it was pretty close in terms of looking at the ventricular stroke volume and the aortic valve flow. And also it was about a third, I got the stroke volume of I mean, the LV stroke volume was about, I think, 500 ml per minute, multiplying the stroke volume for the heartbeat by the cardiac output, which is close to 30 to 40% of the combined cardiac output, which would be normal for the baby. We cannot adjust it to the fetal weight as we would do it in a fetal echocardiogram. But it was pretty close, so I thought it was a nice addition. However, for reporting purposes, it's still mostly qualitative analysis. But hopefully that will change with more literature coming up.
I think there have been one paper in the last year with reference values coming from Denver, having quite a few nice results on that. They have also normalized it to fetal weight. We are offering this now as well on our software platform. It's for free. So if you're interested in calculating the fetal weight, we can help you now. So and we can give you access to our post-processing pipeline. And then it's a 10-second sequence. You run that, and based on the AI network, we segment it, and you get the fetal weight out of that, which means you can normalize your measurements to the fetal weight. So very happy we have developed this, or we are working together with this with the guys from Children's Colorado. They have basically developed it, and we are implementing this, and it works already pretty stable. And it's nice to see that you have the 3D baby that you can turn around. It's quite fun. But also the values are accurate, so it's also good. Yeah, so if you're interested in that for your functional measurements, Bettina or Max, are you using functional analysis on your cardiac exams?
I do it when the short axis stack is good enough to analyze, and I only like to provide data in a report when I can sort of stand behind it and believe it.
Sure.
So when it's good enough, I'll report it, and if it's not, I'll just do qualitative. Function looks normal. But I have done it, and obviously it
Okay.
works like any
Okay.
other heart. You can contour whatever you want to contour, but yeah, when it's good quality, I'm happy to do it, and there is that normative data available.
For me, it's the same. I'm doing it like Max. Yeah, and if I have the whole stack, then I'm doing volumetric measurement and function, and also estimate left ventricle versus right ventricle. But as we know, yeah, we have no data so far, which are standardized in the fetus. So I only report it in our center when we discuss it in our conferences, but not like an official statement.
There was one question very quickly, maybe to the speakers, as we are already through this webinar. How many fetal cardiac MRI studies do you perform per month at your center?
I can say two or three. Because the slots are very hard to get, and I do two a month.
We're doing it at the moment, I would say, on average, 1 a month. When we started, we were doing quite a bit more, and it's unfortunately kind of petered out a little bit. We've had quite a bit of pushback from HMOs, one who will refuse to cover in particular. So it's been an issue. So if anyone else has had that experience, I'd like to hear how you've got by that.
Yeah, so we're still in the early stages. I would say we do about a case every other month. But that is, I see that, a need to increase with, being able to see better, like compared to the very first scan we did to the recent scans. So I think that will give us more buy-in and get more patients, hopefully.
Yeah, that's true. Of course, the more patients you have or the more regular scans, then we see also an improvement, of course, in the training and in scanning and also being comfortable with the application. So I think I would call it a wrap. We are already 5:15 here in Germany. Thank you so much, everyone who stayed until the end now. And of course, a big thank you to our speakers. Thank you very much for preparing the cases and showing and sharing it here with the community. This is always very valuable.